Hello.
Hi there.
Welcome to From Skirts to Scrubs. I'm Alicia,
And I'm Charlotte.
and we are two OBGYN residents trying to figure out our place in medicine by looking to the past and to current events to better understand the impact they have on us as women in medicine and women in general.
Yeah, and you can find or follow us on social media. We have an Instagram and a TikTok, which are both at From Skirts to Scrubs. We have Twitter, which is at FSTS_podcast. And you can also check out our website for more information on our episodes, show notes, sources, and more at FromSkirtsToScrubs.com.
Yes, and you can also subscribe to our podcast and leave a rating and review. Apple Podcasts is the best place to do that, but you can also do it on Spotify, and we're also now on YouTube, and we have live streams of our episodes, so be sure to check that out as well, and you can like and subscribe there.
Yeah. And welcome back to episode 65, I think this is.
Yeah.
This week, crazy. This week, we're
Chugging
going to
along.
discuss a very common experience that the majority of people with uteruses will go through one day. Which I tried to look up the statistics of, and I couldn't really find anything, but maybe it's because I was writing this episode at 1 a.m. This very common thing that these people experience is pregnancy. And we're not specifically talking about pregnancy today, but we're talking about labor. And so I want to dive into like what labor is, common obstetric emergency room complaints that have to do with labor, and then a little bit of like historical context about labor and people like experiencing labor. So usually here I would ask Alicia like what you know about labor, but you kind of know a lot. So if you just have any thoughts before we start, then go ahead and tell us them.
You know what? I do have one thought that I'll share because I actually recently was interviewed for like a magazine, like a college magazine article about misinformation in gynecologic OBGYN sphere.
Oh,
And
there's
a
so
lot
much.
of that is
I was like
due to
commenting on
labor.
TikToks the other day being like, the misinformation is so bad.
The misinformation is insane.
Yeah.
And I never really thought of our podcast as a podcast that like tries to tackle misinformation because we're also like more vibey. We'll like talk about history and we'll chat. But I'm like, no, I mean, we do always like cite our sources and we like do these deep dives into these really involved topics. And so when it comes to labor, like, again, we always say our podcast is not meant for medical advice, but like,
No, not at all.
we always try to be very informed and evidence-based and like not contribute to fake news. And so I'm excited to like talk about labor and like
Yes.
evidence-based labor, even though that's not really what we're talking about. Like we're kind of talking about real things that happen to people during labor.
Yes. And to be honest, I read the Williams obstetrics textbook chapter to write this episode.
That it does not get more down to the
More
roots than
legit
that.
than that. All right, so let's do this.
That is so funny. For background, Williams obstetrics is like the holy grail of like
Yes,
OBGYN.
it is.
It's like
It
what
is
all of the
textbook.
trainees need to read. It's like
Yes.
the go-to
It's like the textbook
text.
that weighs 500 pounds, that kind of thing. But I read the ebook, but still.
Yeah, I have the ebook. That textbook would break my back.
Okay, let's talk about it.
Let's do it.
My computer's starting to sound like it's gonna like take off. Literally. I'm gonna drink my coffee. I don't know why my brain thinks it's so early. It's literally 9:45. Like, it's fine. It's not early at all.
Yeah, I woke up at 7:55. I don't know why I was being such a baby yesterday.
Yeah.
Like, oh my God, I don't want to wake up at 7. My eyes opened at 7:55. I was like, this is a very reasonable time to wake up.
Yeah.
I feel great.
I was like, what is wrong with me? Okay. So labor? What even is labor? When you think of going to the hospital to have a baby, you usually go to the unit called labor and delivery, which are two different things. Like labor is its own thing, and the birth of your child, aka the delivery, is also its own thing. So today we're only going to be talking about the labor part of labor and delivery. Delivery is a whole separate topic that we will talk about a different time. Because there's so many fun things to discuss with that we don't need to cloud them all together. And L&D is like a wild place. I'm currently on an L&D rotation, and it's either like the most chill place or it's like absolute chaos, and there's really no in between. So we'll try to keep labor as simple as possible today. All right, so what is labor? Like technically, what is it? So I'm going to say this directly from Williams Obstetrics, the Holy Grail OB book, as the definition. Labor is characterized by forceful and painful uterine contractions that affect in cervical dilation and cause the fetus to descend through the birth canal. So that's it. That's what labor is. It is literally when you're pregnant, your uterus is having painful contractions, and those contractions result in cervical dilation. And that's it. So we're done with the episode. We'll see you next time. Okay, so.
And that's labor.
And that's it. That's labor. Thank you. Just kidding. No, I'll explain some more. We'll get into like the nitty gritty a little bit of how labor works. Because honestly, like I didn't really know the physiology behind it. I'm not going to get into like these like niche physiology things, but I'm going to try to explain it in more layman's terms of kind of what's going on in your body, because it is like a crazy experience to go through. Because one day you're just like pregnant and chilling, and then the next day you're having like this terrible cramping pain. And you go to the hospital and you find out you're in labor, and you're like, "What the heck? What caused this? Like, why am I here?" And there's still a lot of debates to what like exactly initiates labor, but the current theory is that it's a combo of factors from both mom and baby and placenta. And we're going to try to break it down a little bit. And this is definitely not perfect. I read that whole textbook chapter and I was like, I don't even know what some of this is talking about. So we're going to do our best. Okay, so 1, the uterus, big part of labor starting. The uterus itself is basically a giant muscle. There's many different layers within the uterus. Alicia knows these things. I usually teach her things, but she knows this.
No, this is great. I love it. I love a like review.
A review,
and
an anatomy
it's helpful
review.
to know because it's also like when a patient comes in to the hospital or a
Yeah.
laboring person is there, how are you going to describe it to them? Like,
Yeah,
you're not going to
exactly.
be like, the uterus is contracting.
Like, right. Yeah, because why is it happening? So the uterus has many different layers, but it's mostly muscle. And the type of muscle it has is very specific. It's called smooth muscle. There's many different types of muscle that we don't need to get into. But this type of muscle is very reactive to inflammatory processes. And throughout pregnancy, the inside layer of your uterus that is actually like attached to your placenta is acting as a layer that inhibits inflammatory process. So all through pregnancy, it's like doing its job to keep inflammation down in the uterus and in your body. But once it gets near the end of pregnancy, it reveals that it's a double agent and it's like, bam, we're going to make everything super inflammatory. It releases its own inflammatory factors and it like stops doing the anti-inflammatory jobs. Like it releases its own and lets everyone else in. And this causes that muscle in your uterus to react. And so when it starts to react, this specific muscle type acts like dominoes in a way. So like once one domino falls, they all fall. And if you imagine like a circle of dominoes and the inner layer falls and they like all fall and they have like a wave, that's like exactly what this muscle contraction in your uterus is. So it's like all the muscles are contracting in a wave. If you imagine like a stadium wave, that's exactly like the type of muscles which is causing that contraction. That's like a force that pushes your baby down. Yeah. So it's like squeezing down. And so that's how contractions happen in the uterus. Very glazed over version because the biochemical changes is not important right now, but there's a lot of hormone changes that kind of leads to this reaction in your uterus. So that's contractions. That's the first thing you need to be in labor is have contractions. The second thing you need is your cervix to change with those contractions. And so when the cervix starts to go into labor, there's also many changes that it goes through. And one of the important things that happens is it actually like the material of the cervix goes through changes as well. It goes from being like, if you're a non-pregnant cervix, apparently I learned this, the consistency of it is like the cartilage of your nose. Yeah, I never really thought about that. And then I was like touching my nose and I was like,
it
I
does
guess
kind of
so.
feel like this.
Yeah, and then it gets a little softer throughout pregnancy, but then when you're in labor and it starts to dilate, it gets so soft that it feels like your lip. So if you feel like your like literal lips on your mouth, like that's what the cervix feels like. Alicia's measuring her lips like a cervix. And honestly, like kind of
like
feels
a 6
that way.
centimeter cervix. Yeah.
I'm like, this feels like 70 to 80% of face, like how my lips.
That's so funny.
And so yeah, cervix becomes more soft. And this is what we call cervical ripening, is your cervix getting soft and starting to dilate. And basically the matrix of your cervix, like what's in the middle, is kind of like these cross-linked fibers. So if you imagine like spaghetti noodles that are cross-linked across each other, that's what your cervix looks like. And when it starts to ripen, secondary to hormone changes, those spaghetti noodle structures start to get a lot more messy. So Imagine you like had a box of spaghetti noodles and then you just dumped it onto a table and it was kind of a mess. Like that's kind of what your cervix changes into structurally when it starts to ripen. Additionally, there are molecules that like start to come into the cervix that kind of are wet and stretchy and kind of like are like putty over those stretchy noodly mess. And this keeps your cervix together, but allows it to like really stretch out and really thin out. So that's a
Mm-hmm.
really important part of allowing your cervix to ripen. And there's two parts, like even more to this. Okay. So we have effacement and dilation. And these things I always explain to patients because when I'm doing checks on them, checking their cervix throughout labor, I'm telling them, you are 0 to 10 centimeters dilated. And sometimes you go in, you're like, you're still 5. And people get really frustrated. But I'm like, hey, you're 5, but you were 30% dilated before or something. And now you're 60%. And like that part's also really
Effaced.
important. You are 30% effaced. And now you're like 60% effaced. And that part's important too. So your cervix has to dilate, but also has to go through effacement, which is the process of your cervix getting really thin. You can't have a
Mm-hmm.
baby when you're 10% dilated and your cervix is 3 centimeters thick still. Maybe
Yeah,
you could, but you'd probably rip your cervix, which is really
no,
bad in
that's
emergencies
bad.
sometimes. And so,
I also don't know in your experience if you feel like this is true, but I feel like a lot of first time pregnant patients that I take care of, they'll often like thin out before they stretch. So,
yeah,
like, I will feel a cervix that is 3 centimeters dilated, but it's like paper.
yeah.
And then I'm like, that's great. That's
And then you
actually
go and you're like, whoa,
amazing.
yeah,
I know, because then like once it's thinned out, like, isn't it so much easier if a baby's head is like on it,
yeah. It's
wouldn't
just
it be
putting the
so much easier
pressure.
to just open? Like, that's what I always tell
Exactly.
people.
And so, yeah, you like need it to get so much thinner. And so I always explain that to patients because people get so frustrated with the dilation because that's like what people talk about. But I'm like, you need both things
Right.
and you need the baby to come down, which is a whole nother part as well, the station of the baby. And so I think it's just important to talk through. And so with the cervical ripening, dilation is, 0 to 10 centimeters. And this is from a combo of forces from contractions and like the actual membranes about around baby pushing on your cervix. So the contractions are like a force that's like pushing the baby down on the cervix, causing that pressure to get it to dilate. And then same with like the membranes around baby pushing down on the cervix, causing it to dilate. And then effacement is like literally your cervix melting away. Like I always tell patients, like in order to have a baby, your cervix needs to dilate and it needs to melt away. And that's exactly what the effacement part is. And so, like Alicia said, it literally needs to be paper thin by the end. And the way this occurs, which I thought was cool because I didn't know this, like the physiology behind it, is that the tissue of the cervix, because I was like, I don't personally like, where does the cervix go? It like blends into the uterus. And so like all that
That
tissue
makes
that's
sense.
in the cervix just kind of as it dilates gets pushed back and it kind of gets incorporated into the lower uterine segment, which is like the bottom part of the uterus during labor. And so it kind of just all meshes into that. And then once the baby's born, it comes back out and forms the cervix again. So I thought that was kind of cool because I personally never really understood where the cervix went.
Yeah. And when you're feeling too at the end, you're kind of like, is this cervix? Is this uterus? Like, it all feels so similar. Like,
Yeah.
I have many times been like, oh my gosh, her uterus is like boggy or like doesn't have good tone at the end of a delivery. And I'm like, no, that's just her cervix. Actually, she's
Just
tone
the
is
cervix
great.
flopping
Don't
around.
worry, we're
Yeah.
good. But like, I couldn't tell the difference because they feel so similar. And
Yeah,
like,
exactly. It
am
like
I
meshes
like, yeah,
together, which I didn't realize that's cool. So that's basically how labor works. You have your contractions and then your cervix changing. Those two things together equal labor. Now, if you have one or the other, those are different things, but they have to
right.
be together for you to be in labor and to be admitted to like labor and delivery under the context of labor.
Labor.
There are other things, but we're talking about labor. And then I also just want to quickly talk about like why labor is painful. I think I would like to do an episode eventually on like specifically obstetric anesthesia and like how labor pain is treated. So I'm not going to get into that, but I just want to, since we're talking about labor, kind of discuss the theories behind the pain like super, super fast. So, Alicia, do you know why labor causes pain or like what the pain is from specifically?
That's such a great question. Is it something to do with prostaglandins?
Maybe
Is
it's a
it?
little bit more
No?
like
That was a true guess. Because prostaglandins can be painful, and I know that like they
that's
are
true. And
a
prostaglandins have a huge
chemical.
part in like labor as
Right,
well,
because we use prostaglandins to like start cervical dilation and ripening and
Yeah.
so I was like, maybe okay, just tell me.
Okay. So
I
there's a
don't
couple
know.
different theories as to why labor pain exists. One is that like as your uterus is stretching and like doing all its contraction motions, it's putting a lot of like stretch on your perineum, which is the tissue that's underneath like the skin of your and muscle of your abdomen, and that's causing pain. That's one theory. The other theory is
Okay.
that as the cervix dilates, it's the nerve endings in your cervix is causing pain. There's another theory that as the uterus contracts, like with each muscle contraction, the muscles are squishing the blood vessels between each muscle, and it's decreasing the blood supply to the uterus during contractions. And then that contraction decreases like the oxygen going to the muscle, and it's causing pain, much like how you have pain with a heart attack. It's like the lack of oxygen supply to the muscle causing pain. Those are all some theories. The most like the theory
Agreed
that people think
upon.
are is most likable right now and plausible is the theory that as the muscles of the uterus contract, it's putting pressure on the nerves of the cervix. And so all of your nerves in your body like originate in one big nerve that branches out to the other nerves. And it's a theory that the uterine contractions are putting pressure on that cervical nerve, and that's what's causing pain.
That's really interesting though, because I feel like when people are experiencing labor pain, their pain is not like cervical.
I
And then
know,
that also doesn't really check out for me because I'm like, but then why does an epidural need to be at like
a certain level.
T8 or whatever, T12? I don't know.
I
Sorry,
don't
OB
know.
anesthesia. I do not know the levels.
Yeah, we'll get
But
to that
like
one
it's
day.
way higher than the level of the cervix. It's like almost to the umbilicus or higher. So
Yeah. And then, like, one theory or one reason that people like that theory in the Williams obstetrics book was because, like, cervical, like, blocks or whatever, like, work super well for labor pain or something. And so,
yeah, but like
or like pericervical blocks. And so they were like, this
but
must
for
be it.
all of labor pain? Really?
Yeah, I don't know. I think that's why there's so many theories as
I'm
to
gonna
why
ask one of
it could be
our
causing this pain.
anesthesiologists. I'm fascinated now. I never
Yeah.
really thought about this. Like, why is labor
Why is it so
painful?
painful? Like, I don't know. I feel like in my head, I'm like, obviously it's painful, but why? Why is it obvious?
Yeah, it's not obvious actually. It
Yeah.
just is. It's like one of those facts.
Yeah,
That's
exactly.
fascinating.
Yes, which is why I would love to talk about OB anesthesia with like an
With an
anesthesiologist at some point,
anesthesiologist.
like not like us being there, but like
No, not us
really,
guessing.
really like an anesthesia person like telling
Not
us
us
stuff.
sharing theories.
Yes, exactly. So that is labor. That is the sciencey stuff. So we're gonna stop talking about science and get into more of like the real life stuff. And I
Mhm.
just want to run through like what are some real life labor complaints? Alicia, what is stuff that people come in to the obstetrics triage with?
Abdominal pain.
Yes, people come in and they're like, I'm having pain in my belly. I am having, I think, contractions, or I don't know why I'm having pain. You put their baby and their uterus on the monitor, and you're like, yes, you are contracting. And it's a super, super common OB complaint. So, say you come in, you're like 39 weeks, and you come in and you are seen to be contracting on the monitor. Maybe it's your first baby. You didn't know what contractions feel like. You're like, I'm just having this pain. It's weird. We check your cervix and you get there. And a couple hours later, as long as you're like not actively having a baby, we like check your cervix again and you've made change. Your cervix has changed because of your contractions. We're like, great, you're in labor. We roll you over to L&D. That's it. Great. Say you don't make change. You're having these regular contractions and you're not making change. Unfortunately, you're not in labor and we're going to have you go home, give you really strict return precautions. So if the pain gets worse, comes closer together, your water breaks and like that, you are welcome back at any time. I've literally sent patients home in the morning. They come back at night and now they're in labor. But unfortunately, we can't keep you all day if you're not actually in labor. And so
Yeah.
that's great. Also, if you
But
come
like when
in,
you come to the hospital, like bring your bag. Like if
be
you're like
ready.
getting close to it, like bring your bag that
Yes.
has all the stuff that if you have one, you should try to have one that has like
Yeah.
all the things that you might need
Whatever
if
you
you
want in
like
it.
go into
Mostly a
labor.
phone charger.
Phone
I feel like people
charger,
ask for phone
extra
chargers. We don't have
clothes.
that.
Yeah, I know. We don't have a lot of things. So like just bring whatever would make you happy if you're in the hospital and you're like, I'm pregnant and I'm in labor and I like need X. Like bring
Yeah.
those things.
Yes.
And even if you're not in labor, at least you get to go home. But like the worst would be you come and then you're like, oh my God,
And now you're
I have to
stuck.
stay now.
Yeah. You're here for multiple days now.
Mm-hmm.
Yes. And so the contractions that you have that don't result in cervical change, those are the Braxton Hicks contractions that people I feel like commonly talk about. And so they're really like practice contractions basically for your uterus. And it talked a little bit about it in the textbook of that, like it's your uterus like starting to make those changes needed to be in labor. So the muscles and the hormones and things are starting to change, starting to get the things going to be in labor, but they're not quite to the point of labor yet. So you're
Mm-hmm.
starting to have these like practice contractions basically.
And they can be short, but they can also be pretty
They can
long.
be pretty painful and
They
like
can be painful.
very
I feel like people
labory.
come in and they're like, I had a contraction and it lasted like 2 minutes and it was so painful.
Yeah, and
And
you're like,
so I
"What?"
came in and you're like, ooh, that sounds not fun. But
Yeah.
also, that doesn't necessarily mean you're in labor unless your cervix is making change.
And it
So
can be
don't
really
be alarmed.
frustrating to patients. Like I had a patient who came in like 4 times in a couple of days because of like ruling out her labor. And every time I was like, I'm sorry, I have to send you home again. And she'd be like, that's okay. I understand. But like it can be frustrating and
Mm-hmm.
painful. And people will be like, well, what am I supposed to do about this pain? And I'm like, yeah, I know. Like
I
I'm
know.
sorry. It sucks. And so also, another common complaint is like, say you're 34 weeks and you come in and you're having labor pain, and we check your cervix and we check it again and you're in labor, but you're 34 weeks. You're not term. That baby is going to the
Yeah.
NICU. That's called preterm labor and is not great. And like, you're going to be seeing MFM, you're getting a whole workup done, all these things. And we're not going to talk about that today, but that is also still legit labor. You're just in preterm labor, it's called.
Yeah.
And once again, we're talking about normal labor today, but that's a very common complaint as well. And then, Alicia, what's the other common complaint?
Leaking fluid.
Exactly. If you, people come in all the time who are leaking fluid and they're like, I don't know if it like when it started to notice more discharge or notice more fluid, or they did have a big gush and they're like, I think my water broke. Like there was so, like I was wet all of a sudden. I don't know what happened. So you come in to get evaluated. There are a couple things that are done to make sure your water broke or didn't. We like do a speculum exam. We take some swabs of the fluid we see. We do like an ultrasound, all these things. If your water broke, you're staying. Even if you're not in labor, you are staying because now your water
Mm-hmm.
is broke and we need to induce your labor, or if you're kind of in labor, like help it along. Because if you water's broke for too long, basically you're at risk for infection. So you're staying if your water broke, no matter what
No matter what.
gestational age
Mm-hmm.
you are, you will be put in the
No.
right place to manage that from there. But if you're full term and water broke, you're staying. If your water did not break and you're not in labor, you're going home. And it's honestly super common for people to come in with concern their water broke and we send them home. Like
Mm-hmm.
more common
I
than
mean,
people
because
who
people
come in
pee
with the water break.
themselves,
Yeah.
people's cervical mucus changes as it's
Yes.
getting ready. If we were talking about all of those changes the cervix goes through with the spaghetti and the mesh and the like
Yeah.
changing
People who
and
lose their
all of
mucus
those,
plug, which is
right?
a
Like all
sign of the
those,
cervix starting to change. And
exactly.
like,
All those changes cause cervical like changes. They're just not necessarily dilation or thinning out, but
exactly.
it's like there's
There's
mucus changes and
physiological changes
discharge
happening.
changes,
Yes,
and you might have
exactly.
like a ton of discharge and that feels like your water broke and actually it's just discharge, which no
Yeah.
one really talks about, but it's
Yeah.
true.
And it's so common. People will be like, no, now I feel so bad that I came in. We're like, no, like we want you to come in to the obstetrics
Yeah.
triage. Like we want you to be evaluated. These workups are not a hindrance on us. Like for us, it's like, okay, I got like me, my baby little intern brain can handle water, like a rule out of labor and a rule out of rupture membranes workup quickly. And so we want you to come in and be evaluated.
Mm-hmm.
And so that we can determine if you have to stay or not. Because if you have to stay, then that's important. And if you have to go home, then that's okay. And you'll just come back. So, say you do have to stay and you get admitted to labor and delivery. And now you get to meet little old me. And you're going to be seeing a lot of me on labor and delivery.
So
I
much.
am your main person. I will be talking to you all the time. I will be checking your cervix intermittently. I'm going to be seeing how you're doing. We're going to talk through the process. When I'm not in the room with you, I'm going to be staring at your baby's heart rate on the monitor the whole time and probably running into your room to intervene as needed. And so, really quickly, a couple of things that happen when you're in labor on labor and delivery. There are Now you're in labor. Now you're here. There are 2 stages of labor. And I don't want to get like super into this because it gets very like medical schooly, but basically there is the latent phase of labor, which is when you're like not dilating all the way up to 6 centimeters, not the technical 6, like 5.99 centimeters.
You can
And the
also
6,
call it like early labor, which is like
yes.
another way that
And
0
like
to
you
6.
this takes a long time. And this is the stage where like when moms are getting frustrated, they're like, well, I've been 4 centimeters. Now I'm just 5. I'm like, this is the time where it's okay for it to take a while. Like, I'm not in a rush right now. Your cervix is doing its thing. It's changing. We're trying to get your contractions under control, get them strong. Like, this is the time for your body to figure out what's going on. And that's okay. It can take a long time. And I'm not worried about it. And then you're in active labor when you hit 6 centimeters. The 6 to 10 centimeters is expected to go faster. This is when, like, if you call someone 6 centimeters on labor and delivery, it's a big deal. Like 6 centimeters, people are like, are you sure? Are they actually 6 centimeters? Like, it's a big call to make. You have to feel very comfortable doing because this is when things kind of go on the clock. Because studies, I'm not going to get super into it, but studies have shown that like if you're taking too long to dilate, for your cervix to efface and get softer, or for the baby's head to come down in the 6 to 10 centimeter stage, at some point the thing's not going to happen, and we're going to recommend a C-section for the baby's safety. And so this is the time where it's on a clock, basically. And those are your 2 stages of labor. And so you're chilling up until 6 centimeters, and from 6 centimeters you're still chilling, but we're kind of watching you closer, if that makes sense. We're not worried, we're just watching you. And then the other thing that happens on labor and delivery are labor interventions, more specific to like actual labor, like putting your body into labor type of intervention. So one, your body could just be doing your own thing and we don't have to intervene. We don't need to break your water. We don't need to give you
Expected
Pitocin.
management.
Yeah, your body's just chilling. I had a patient come in the other day who water broke at home. We wanted to start Pitocin. She didn't want it. We said, okay. We talked to her about it. She said, no. Great. She did it on her own. She had the baby, you know, and it was beautiful and it was great. We can also augment your labor. Your body's doing the thing, but maybe needs help, which is what we were recommending for that woman when we were like, let's give you Pitocin to help, kind of move it along, contracting stronger. And she said, no, she would rather her body do it. And so we were offering augmentation of labor, but her body was still doing it alone.
What is Pitocin, Charlotte?
That's a great question, Alicia. Pitocin is the hormone that's released in your body that starts that is moving contractions alone is called oxytocin, which, fun fact, is the same hormone that's released when you breastfeed. So Pitocin is just the synthetic version of oxytocin, and it just helps us get your contractions to move along. And so when we're inducing your labor, meaning we are putting your body into labor, which could be for many indications, and I'm sure we'll talk about at some point, but you can either be just doing it for funsies because you want your baby to be born at 39 weeks or 41 weeks, or because it's medically indicated. Either of those reasons, we will induce you for labor. Your body is not naturally in labor, so we have to make it go into labor. And to get those uterine contractions to start, one way is to use Pitocin, which can help us get strong, regular contractions, which are what we need for labor to happen. And that's other things that go into an induction that we're not going to talk about. But basically, inductions are how we get your body to go into labor. And so that is kind of the gist of labor within labor and delivery. There are so many more things that happen on labor and delivery, but very specific to labor, those are the things that are kind of occurring. All right. So let me take a breath. Before we wrap this up, I want to talk about just like a tiny bit of history stuff that have to do with labor and laboring. There's a lot of stuff in history about like childbirth specifically, which is really fun to talk about and very interesting. But I want to leave that for like our delivery, like the delivery part of labor and delivery episode where we actually talk about childbirth. So today we're just going to be talking about like literally labor, this process of getting to the delivery. Okay. And so couple history facts. In Tudor England, there was this practice of lying in. Do you know what that is, Alicia?
I feel like I've heard of that. It's like, I don't know though. I feel like when I watched the Tudors, like on the CW, they talked about lying in, but now I don't remember. That was like a decade ago. So I don't know.
Yeah. No, it's like basically this process that when it's for wealthy and affluent women, when you are about to like reach your 3rd trimester, about to deliver soon, you start lying in weeks prior to delivery. And it's a time of like peace and prayer, I guess, where you're required to sit in a dark room and basically lie down and you pray and people come and like pray with you. And it's supposed to prepare your body for labor. And you have to sit in a dark room because it's supposed to like imitate the womb. Like you're like in
What?
your own womb getting
Why do
ready
you need to be in the
go into
womb?
labor. I don't know. But it's called lying in.
That is so funny. It's like, why do you have to be in the womb? Your
Yep.
baby's in the womb already. It's okay.
They're just preparing. They're like,
That's
I'm getting
so
ready,
funny.
preparing for panic. And I mean, in the olden days, like people, it was like 1 in 3 women would die in childbirth. And like I said, we're not talking about childbirth, but like to add some context, like women would get pregnant and then write their will because like the likelihood of them dying was so high.
Yeah.
That I'm sure this was also like for women who had the money and time to take a break before delivery were like, I'm going to rest and cherish these last weeks of my life because the chance of them dying was so high.
Yeah.
Really scary. But that's not true for all women. Like this is really just affluent, wealthy women at the time. Most women who were working women and did not have these privileges worked up until the day they delivered and then probably worked right after they recovered from their delivery. There was no maternity leave like there is today. Another part of labor is like laboring positions. And part of this kind of overlaps with delivery. But I do think like when you're in labor and experiencing contractions, you're still walking around the room. If you're not having an epidural, you're kind of like in these positions to deal with this labor pain. That's all part of laboring positions, not just delivery positions. And so, Alicia, what are some like, if you had to think in history, like laboring positions?
Like hands and knees, squatting, anything that uses gravity. Like those are also just better ways to labor.
Relieve the pain. Yes, exactly. And so birthing stools was a really big thing in history. They're basically like circle stools that look like toilet seats almost. Like if you look up a picture of them, they literally look like a toilet seat. And these date back like literally throughout history. Like there are birthing stools from like Babylonian times, like 4,000 years ago. And so extremely common practice for laboring. Also seen like in Egyptian, like wall paintings, seen in like Greek art, different ways that people would be standing and squatting using like this furniture that was made for birthing throughout time to help with that. And then there even has been like birthing stools found that are like collapsible, which remind me of like foldable chairs. If people think that maybe midwives like carried these around like from birth to birth so that women could have like these birthing stools.
Interesting.
Which is kind of cool.
Cute.
Yeah. And so, yes, the like squatting position, hands and knees, women will do still today, or like sitting on a ball, I feel like is also like the modern birthing stool almost in a way. You're not giving birth on the ball, but like that position of like sitting and squatting.
Yeah.
For sure. Okay. What about today? Like, how do a lot of women labor today? Like, more commonly? In the bed.
And it's because, like, we leave a bed in this big empty room and they're like, I guess I just have to get in this bed. It's like, actually, you don't have to. You could, like,
yes. And some of my favorite nurses will literally, like, tell their moms or their laboring patients, like, my expectation for you is if you want an epidural, until you get that epidural, you are walking around your room. You are on the ball. You are moving. Like you are getting this baby down yourself. Like you are walking around. You have the ability to move your legs still, so move them kind of thing. And it's true, honestly. Like you're in labor. It's not the point of the episode, but like you're in labor for so long that like your risks of clots and like all these things get so much higher when you're sitting in bed the whole time. Like you should be up and moving. And also you need that baby to descend into your pelvis, which requires gravity and for you to move. Right. Birthing beds are extremely common. Like there's a bed in every room. We deliver with a bed, all of these things. And they were actually created in the 1500s in France. And this is kind of crazy, but there's this quote I found in an article that talks about how King Louis, I haven't read Roman numerals in a time, I think Louis the 14th, and this is really crazy. He was very perverted and he enjoyed watching women give birth.
Ew, what? That's
it gets
weird.
Worse. And he was really frustrated that by women birthing in like stools and standing and squatting that he couldn't see them giving birth because it was like an obstructed view. So he was a big role in like promoting the reclined position of giving birth so that like people could watch. Isn't that so gross?
That's
And so he
absolutely crazy.
so he was a big pioneer of like trying to get birth to be in beds, and he also insisted that like males also attend births. 'Cause before and even after this too, like even like the fathers of the children like wouldn't go to the birth, and like he was a big like, no, you should go to the birth and like watch her give birth, but like in a weird way, not in like a supportive way, you know?
Wait, when was he around again? This is crazy. This is going to be
15
my like new fun fact for life.
Well, he was around in like the 1600s. That's when he was born, but like the beds being created started in the 1500s. So like they started being a thing in France, and then he was like, this is great. Like we should make this a bigger thing. Isn't that
That's
gross?
so effed up.
I know.
Crazy.
I was like, what? Oh my God, wild, right? And then so that's gross, very gross. And then on top of that, like they were just straight up beds. And then the actual stirrups, which is where like the legs are suspended in a like lithotomy position, is the exact position it's called when you're laying out of bed and your legs are up. That was added to laboring beds in like the 1800s. And so that's the common way of giving birth today, which I said we'll talk about delivery later, but the common way is that you lay on your back with your legs up. And I actually did my first hands and knees delivery last week, so I was pretty excited about that.
Hey,
I was so
love a
confused.
hands
I
and
was like,
knees.
my senior was like, I'm just gonna like, she was like, I'll talk about it later.
It's definitely confusing, but I feel like once you've done enough,
Because you're delivering a
you kind
baby
of are
upside
like,
down.
yeah, you're doing it upside down. I remember
Yeah.
we did a lot of those in my med school, and I like didn't understand the logistics.
Yes.
And then I did one, and I was like, and in residency, and I was like, oh yeah, this
Yeah.
makes a lot more sense
It's just
after you
upside down.
have the muscle memory of like delivering a bunch of
Yeah, exactly. And so we can talk about laboring the delivery positions more later, but that was crazy and interesting. And then what's like the last way someone could labor?
like on their side.
Okay, yeah, but like not in a bed.
Like
Where can people labor? It's usually not
like
in
anywhere.
hospitals.
What?
Or you could have it in a hospital. We have 2 rooms that have the ability to do this.
Tubs.
Yeah, like in water. You can like labor in a pool. And so
Yeah.
this kind of originated, I mean, I'm sure people labored in pools a lot, but the article I was reading talked about like in the early 90s in Russia, there was like a swim instructor who encouraged like home births and like laboring in pools, and it got really, really popular from that. And then in the 70s, like 1970s in France, once again, I don't know why France is so into like how women labor, but
Louis.
yes, literally.
That's
But the
so weird.
1970s, so not even that long ago, like France brought like birthing pools to hospitals. So you can like labor in a pool at a hospital still. And so not all hospitals have the option. Apparently, we have 2 rooms at our hospital that have a pool option. I've never seen someone use
Charlotte,
it, but
move your microphone like further away from you. You're like
hitting it. I've never seen like someone use the pool, but supposedly they can do it. And so that's one way too. But people get kind of frustrated like on certain labor units if they're really worried about baby because you can't monitor the baby when you're in the pool. So it's a shared decision.
It's
Basically.
like a lot of I feel like you have to be very, very low risk.
Yeah.
And at the hospitals that we work at, people are
not
not
low risk.
like usually low risk, and so it becomes hard.
Yeah.
I don't know. A lot of people at my med school's hospital delivered or like labored in the tub, but it was better because the rooms themselves, the bathroom had a tub. So it also was like less water everywhere. Like now we have like these freestanding
You
tubs,
get like inflatable
like,
pools. Yeah.
Like ours isn't inflatable, but it just feels very like freestanding. Like you just have like a bathtub in the middle of your room. Like that doesn't really feel conducive versus like at least where I was, it was like bathtub in the bathroom. So you could like leave all the water and grow like all of that over there and like walk back and forth. I don't know.
Yeah.
I think
that makes sense.
it was a little more
like
streamlined.
I do think it's based on your risk too, but yeah, that's one way you can labor as well. Okay, and then the last labor thing, which kind of starts to bridge into anesthesia, so we're not going to talk like too in depth about it, but it's kind of crazy. But it's about that in the 1950s. Do you have any idea, Alicia, like what was going on with women laboring in America in the 1950s?
Well, I feel like that's when the epidural came about. I feel like that's what we're trying to get at.
Around then. But before there's an epidural, what would they do?
What socio-historically? I mean, World War II just happened.
That's true. I don't know
These
how much effect this has on this, but maybe.
it doesn't have any. Okay, okay,
I mean, it
okay.
might
Well,
because okay, I'll just tell you.
yeah.
There was
I
the
wanted to
practice.
guess,
No,
but
you can try it, guys, if you want.
I just feel like 1950s was like picket fence America, but
Yeah.
I don't know how that has to do with any of this. So just tell me.
Okay. So it was very basically in the 1950s, there was this practice that when women were in labor, the goal was to like restrain them and keep them as calm as possible while in labor.
Okay, I was never gonna guess that. That's
Yeah,
terrible.
it's giving the
Handmaid's
rest
Tale.
cure.
It is giving rest cure.
Like
God,
literally.
that was so crazy.
Yes. And so basically what this is that in the late 1800s, twilight sleep was discovered and developed. And so
Oh,
because of war, because we know that war like creates change in medicine a lot of the times, especially in the past, morphine was discovered and so was
mm,
scopolamine. And basically, they figured out that if you give these two medications together, they cause like a trance like sleep where you're not unconscious, like you're conscious and can respond, but like you're very out of it and forgetful. And so, like, you don't remember a lot and you're just very sedated. And this dude in Germany in the 90s named Gauss figured out that you could give this combination to women in labor and they would be super out of it, but still able to like take commands and push a baby out. And which is wild. And it was very unsafe, and, like, we can talk about this a lot in, like, the anesthesia episode, but the gist of it is these 2 like, it's not like they were regulated medications, like, nurses would not their own fault, just, like, the fault of the time. It would be, like, not a regulated combination, they could be, like, unsafe in giving them to women, like, women could die because of giving, like, too
yeah,
much morphine, overdosing on it, but honestly, like, women of the time, like, loved it because they didn't like, it was a pain management option
right.
for them. There are a lot of women obviously who didn't love it, but some people like pushed because they wanted it. But what's crazy is that this Gauss dude from Germany, his theory of like how women should labor is that they should get twilight sleep and then you should strap the woman down by her arms and legs. And so they could not move in labor, put them in a dark room and cover her eyes with gauze and put oil soaked cotton balls in her ears.
What on earth? What on God's green earth
Yes.
is this?
Isn't that literally crazy?
That's crazy.
Wild. And so that was his like thought. And there was a woman's magazine called The Ladies' Home Journal in the 1950s. And it had an article called Cruelty and Maternal Wards. And there was this like
Mm,
quote from a labor and delivery nurse at the time. And I'm going to read that quote to you. Okay. It says, when I first started in my profession, I thought it would be wonderful to help bring new life into the world. I was and am still shocked at the manner in which a mother to be is rushed into the delivery room and strapped down with cuffs around her arms and legs and steel clamps over her shoulders and chest. It is common practice to take the woman right into the delivery room as soon as she is prepared, meaning this preparation would have meant shaving her pubic hair and doing an enema. Often she is then strapped into the lithotomy position, legs in stirrups, with knees pulled apart for as long as 8 hours. On one occasion, an obstetrician informed the nurses on duty that he was going to dinner and they needed to slow things down. The young mother was then taken to the delivery room and strapped down, hand and foot, with her legs tied together.
oh
End
my
quote.
God.
Isn't
That's
that
insane.
crazy? And so this like quote and article caused like uproar and apparently was like a big part of like the feminist music, the feminist movement at the time in like revolutionizing how women are treated in labor and like making it better and humane, like treating women like people when they're in labor. Isn't that insane?
That's
Like,
I mean, I can't I keep saying it. It's insane. That's crazy.
yes, it like I had no idea. And I saw an article that was like, ask your grandma like what labor was like for her because like if your grandma was here in the US at that time, like, like that would have been the age where she would
Yeah,
have given birth.
true.
And I'm like, wow, I don't have any grandmas to ask anymore, but like, I wonder, like, that's
I
so
know.
crazy. And so, oh my God, wild. Especially like the slowing things down and tying the legs together, as insane as that is, like, it's still common in a way. Not the like tying the legs together part, but like working with private attendings who don't have to be at the hospital at every moment of the time. Like they'll be like, don't break the bag overnight because I don't want to come in. And so the mom's like in labor all day, even though she's being induced. Like the bag's not going to break on its own, most likely. Like It's just there are OBs out there who don't want to come in to the hospital because of the way their practice model works. They have to come in from home, and some people don't want to. And so they will literally slow down labor for that to happen. And so it's kind of wild. And that just reminded me, that quote like struck that in me because it's frustrating when you're the resident on call and you're like, why are we not progressing this woman's labor
Mhm.
because someone doesn't want to come to work? It's frustrating.
Mm.
Also, women in labor at that time would be slapped for yelling too much in labor and being in
What
too
the
much pain
heck?
and too loud.
What the heck?
Yes, and something I experienced in med school was a woman like, someone gave birth, I was like a sub-I, and she was screaming because she was unmedicated, and the nurse, like, screamed in her face to shut up, and I was like I literally was, like, shocked. I was so uncomfortable. I should have reported the nurse, but I was, like, a med student who was like, "What is going on?" It was insane. So crazy, and then lastly, like not lastly, there's probably other things too, but the last thing I'll talk about here is that, like, episiotomies were cut, and then people would which is when you, like, take scissors and cut the skin between, like, the vagina and your rectum, and people do it without anesthesia. So they would, like, cut the episiotomy so the baby could come out and then sew it back up together, and the nurse would basically, like, hold the mom down with, like, a mask over her face, and they would do that all without anesthesia.
Mm-mm.
Isn't that crazy? And, like, it's so sad now, like and I'm sure people still experience these really bad things sometimes, and so that's part of birth trauma, which is a whole other episode we wanna talk about too, and things that contribute to birth trauma, but, like, how you're treated in labor really matters to your labor experience and your birthing
Yeah,
experience and can, like,
absolutely.
affect you for the rest of your life, literally, which is, like, why birth trauma is a real thing, which we will get into another time, but this is, like, mistreatment of women in labor, but also that still continues today, like, incarcerated women a lot of times give birth in chains and strapped down, and, like, a lot of times in labor, people do things to the patient without asking her or, like, doing informed consent about things, and it's so important to talk to patients about this, and I think sometimes as a resident, when you're busy, you get frustrated, you have to go and explain everything to the patient, but, like, it makes sense why you do. You need to go and tell them why you're doing these things to them,
Yeah,
discuss the benefits of them, tell them that we're drawing labs because we're worried they have preeclampsia and explain what that means and why we have to poke them for labs again. There's all these things that are happening in labor and delivery, and it's very overwhelming. And I think in the media, there's this perception that labor is like normal and beautiful and perfect. And like doctors are trying to make it not. And as much as I want your labor to be beautiful and perfect, sometimes bad things happen to you or the baby, and we're just trying to make it safe and better. And the only way to bridge that disconnect is through like discussing that with the patient and like having informed discussions and consent. And so
definitely.
these like terrible mistreatment things that have happened in the past to women in labor, or even just the confusion of like, having contractions, but why are you sending me home? Why are you allowing me to be in this? Like, I'm in labor, why are you sending me home? And we have to explain like what this is, what labor actually is though, and this is why we're making these
Mhm.
decisions. All of this discussion is so important for making women's laboring experience better and having like expectations that meet their own what they want out of their experience, but also benefit like themselves and their baby. So that is why we're talking about labor today, and we will have many more episodes where we talk about these like common things that women experience in obstetrics and gynecology that might be confusing or misunderstood because of media, and we want to explain why they are how they are. And that is why we do
Yeah.
this podcast. And so if you would like
That's
to
why
learn,
we do this,
that's why we're
everyone.
here. And so if you want to learn more, you can follow our podcast and leave us a rating and review. Apple Podcasts and Spotify are great places to do both of those things.
Mhm. You can also follow us on social media and check out our website for more information on our show notes, sources, merch, and more. That's from scrubs2scrubs.com. And lastly, here is to the women who have fought for us to be where we are today, and may we do the same for those who come after us.
Yeah, we'll
See
see
you
everybody
next
next time.
time.
Bye.